And optimization starts with the thorough evaluation of the patient. It's not only fancy options, it's when and how you choose these options. This will include the clinical picture of the patient, the proper investigation, optimizing of guideline-mediated treatment, and choose the proper device. And the risk is that even with the best medical treatment, the residual risk is still very high in heart failure patients. So to fulfill these gaps, we need some device therapy well indicated, and we need to know how to optimize this device therapy, starting from the decision of using this therapy to how to refine the use of this therapy. Heart failure is an extremely complex syndrome, and it's not only about the congestion of the patient, it's a whole continuum of neurohormonal arrangements. So there is a plenty of options beyond ICD and CRT use in heart failure patients. Of course, ICD and CRTs were the fundamentals or the cornerstones in helping patients that did not meet the clinical and the imaging criteria of decompensation. So we can use the ICD in a patient with high frequency of ventricular fibrillation or ventricular arrhythmia, and CRT in a patient with immense heart failure without improvement on medical therapy. Of course, we all know the indications of CRT and ICD, but how to optimize the use of these devices? The optimization of these devices, especially the CRT, was depending upon the effect of the CRT on the ECG. But refining that with combining the ECG changes with the echocardiographic changes, especially the strain and strain rate, we can increase the benefit of CRT and decrease the desynchronization that could happen. So using the adding tools like echocardiography to the ECG, the following up the patient with CRT can optimize the effect of the CRT. And we can use the CRT, the already existing CRT and ICD, to remotely monitor the patients. How we can do that? By detecting the heart rate variability, the arrhythmia, the biventricular pacing optimization, and intrathoracic independence, impedance. These parameters could be shown by the CRT device when interrogating the device, and it will help us modifying and improving the condition of the patient according to the needs. And the future is already here in every implantable devices that can provide us with the status of the intracardiac function, intracardiac pressures, the ability of the heart to accommodate the device, and whether there is increase in the pulmonary pressures or not. And this will help us modifying the medical treatment, modifying the reprogramming of the devices. So what about the upgrades? We usually do not upgrade the devices unless it's extremely indicated. But an upstream upgrade of the devices, especially the patients that they need right ventricular pacing, resulted in improving the survival of this patient, decrease the mortality, and decrease the hospitalization of this patient. And this is what our professor was saying, that adding an initial more cost can prevent us with a long journey of costly interventions, costly hospitalization, and mortality of the patients. So, it is good to know there are plenty of implantable devices now to help us optimizing the heart failure treatment. One of them is an automated system to manipulate the autonomic nervous system of the patient. This barostim device can reduce the baroreflex sensitivity, increase it a little bit, decrease the sympathetic tone, increase the parasympathetic tone, and relieve heart failure symptoms. And we have 2 trials on it, the Read Heart Failure and Hope for Heart Failure, that did improve the patient lifestyle, the 6-minute walk test, and decrease the hospitalization of these patients. Another device is a device that improved the contractility directly of the right ventricular septum, which is the cardiac contractility modulation. And cardiac contractility modulation improves the calcium inside the septum, so increase the contractility, decrease the dysynchrony between the right ventricle and left ventricle, and help the patient in his symptom, in the decongestion, and decrease the hospitalization of the patient. And when combined with CRT, the results are marvelous comparing with each one alone. Another problem was the severe heart failure in a patient, severe mitral regurg in a patient with heart failure that are not eligible for surgery. Now, the transcatheter mitral valve replacement is here to try to solve some of this problem. And mind you that mitral regurg or severe mitral regurg is a totally separate entity that contributes in heart failure and prevent the improvement of heart failure in patients. So the transcatheter mitral valve replacement or the implantable mitral valve reduce the symptom of the patient, reduce the negative remodeling of the patient, and increase the survivability of the patient. Another thing is creating a shunt between the left atrium and right atrium, trying to decompensate the left atrial pressure. This is done non-invasively or minimally invasively with the cath, and this reduces the intracardiac pressures, try to decrease the filling pressures of the heart, and improve the symptoms and improve the use of guideline-mediated medical therapy. And it's proven effectiveness in small trials now, but we are looking for a large-scale trials. So there are plenty of devices. Some of them are FDA approved, and some of them is waiting the trials to be FDA approved. And these devices also contributes in the treatment of heart failure with preserved ejection fraction. The whole method that we are facing now, the very difficult patients with sustained dyspnea without an obvious structural cause, these devices, including monitoring devices and interventional devices, can help us treating heart failure with preserved ejection fraction. And this is an algorithm by the FDA that shows us that the edge-to-edge repair, the cardiac contractility modulation, the baroreflex activation therapy, and phrenic nerve stimulation are now approved by the FDA in treating heart failure patients. Of course, we do not ignore the wearable devices, but these devices are either a destination therapy or a bridge therapy for heart-lung transplantation. So it's very, very important to know what's wrong or what I need to modify in the patient, whether it's counteracting the remodeling, whether it's decrease the synchrony of the patient, whether controlling the autonomic nervous system to choose the implantable device I will give to my patient to decrease symptoms and increase survivability. So heart failure is an extremely complex syndrome patient evaluation, reaching first and optimal medical therapy is crucial before thinking about using devices, and thorough understanding of the mechanism of heart failure will help us choose and optimize the use of devices. And thank you so much.